All right, you guys. Hi, everybody. I know some are still signing in, but welcome to this session we have for y'all today on using technologies to serve veterans. We have a couple of housekeeping things, and then I'm going to turn it over to our speaker for today. You guys are all muted for right now, but we will still be talking to you guys using the chat box. So that's how you'll ask questions. If you have comments, feedback for Eric as he's going through the presentation, please use the chat box to communicate with us. We will save about 15 minutes or so for the very end for Q&A, but for the most part, it'll be the presentation that Eric's going to give us. All the sessions are being recorded, and you guys will get a link for this recording as well as slides in our daily recap emails, which go out in the morning following today. You'll get one tomorrow morning, and then every day this week during conference with the previous day's recap. So if you are missing things or you have to sign out and sign in and stuff, you'll get the full session. Yeah, if you guys have questions for me or anything, please use the chat box to communicate with me. And then I'll be back at the very end to read questions out to Eric. I think we'll go ahead and get started here, and I'll turn it over to you, Eric.
All right, well, thank you for the introduction. Let me just turn on my screen sharing so that you all can see my slides. And you should all see the title slide. Well, good afternoon. It's great to be here. I'm going to be talking about some of the work I've been involved in examining the HUD-VASH program's transition to telehealth in response to the COVID-19 pandemic. And so this is joint work between a research group in the Providence VA called Long-Term Care Services and Supports COIN. That's where I spend some of my time doing research, and the National Center on Homelessness Among Veterans, which is in the National VA office, and that's where Jack Tsai and Dina Hushai are. And they've both been very involved in helping obtain the data, help develop the research objectives, and interpret and think about the meaning of our findings. All right. So the plan for the next, 40-45 minutes is to continue to motivate the topic. We'll provide some background on the U.S. Department of Housing and Urban Development VA Supportive Housing Program, or what we'll just call moving forward HUD-VASH. We'll then go into detail on two analyses we've recently completed, examining how COVID-19 and HUD-VASH's associated shift to virtual care affected key process measures. And so by virtual care, I mean things like using telephone and video to engage with veterans instead of in-person care. And so the first objective or question we'll share results on are focused on examining pre-post the shift to virtual care. So after the transition to virtual care in response to COVID to some period before, how has the modality of HUD-VASH case management encounters changed? Are they using more or less in-person care, more or less video care, more or less phone care, for example? The second objective and analysis focuses on examining whether there was a differential response in use of case management for veterans that lived in states that implemented a statewide stay-at-home order in response to the pandemic compared to veterans that lived in states that did not implement such an order. And then hopefully, again, we'll conclude with about 10-15 minutes for an opportunity for questions and discussion with the group. So Housing First is the cornerstone of the VA strategy to end homelessness. It's a policy that's been adopted in multiple countries' health systems. The key principle of Housing First is to provide people with permanent supportive housing without conditions on treatment. As many of you may be aware, in a number of randomized and observational evaluations, Housing First has been shown to improve housing stability, a number of physical health measures, mental health, and reduce the use of acute care services such as emergency departments, inpatient admissions, etc. HUD-VASH is VA's Housing First program. It provides veterans with a Section 8 housing voucher from HUD and case management services from the VA. It's the largest Housing First program in the nation, and it serves more than 60,000 veterans a year. In a demonstration project, HUD-VASH was shown to reduce veteran time to housing placement, increase housing retention, reduce emergency department use, all compared to veterans who were receiving usual care. So a key feature of HUD-VASH is the case management services that are offered within the program to help veterans obtain and sustain their housing. Case managers link veterans with regular health care. They may help the veterans stabilize their mental health. They can address a number of social determinants of health. They can provide linkages or referrals to community-based resources, help veterans obtain relevant benefits, help with transportation, etc. Before the COVID-19 pandemic, HUD-VASH case management was typically provided face-to-face in the community. This could be at the veteran's home, some other community center location, or at VA medical centers. In response to the pandemic, most VA medical centers shifted HUD-VASH clinical services to virtual care, again, meaning sort of telephone or video engagement. And the shift to virtual care corresponds with general VA guidance to transition eligible services to telehealth virtual care. And of course, it coincides with transitions across the nation in various healthcare settings and systems, all in response to the pandemic. To help with the transition to virtual care, the Homeless Programs Office used CARES funding to distribute nearly 20,000 free smartphones to housing insecure veterans. And so there's now, we think, fundamental questions about how veterans engaged with case management. Veterans in HUD-VASH case management, you can envision, may encounter barriers to engage in virtual care due to a number of social economic reasons. They may have complex mental health or medical conditions that may be challenging to address via virtual care. And the veterans and providers themselves may also not like virtual care. At the same time, you can envision there's sort of a number of positive benefits associated with virtual care. Virtual care may help the HUD-VASH program increase program reach, so it might be able to now engage with more veterans. And for veterans in the program, it may enable them to engage more frequently with their case managers and other VA providers, as well as community providers. We think answers to these fundamental questions can help Homeless Programs Office not only prepare for the next public health emergency, but I think more importantly, inform the use of virtual care as a new model of care within the HUD-VASH program. So with this sort of framework in place, we had two sort of overall objectives. The first was to determine the effect or association of HUD-VASH's shift to virtual care during the COVID-19 pandemic on case management services. That is total number of encounters, as well as modality of encounters, in person, video, phone, etc. This analysis is guided by a working hypothesis that HUD-VASH's shift to virtual care during the pandemic resulted in more total encounters, more telephone and video case management encounters, and a decrease in in-person encounters, all compared to a pre-pandemic period. And we'll talk about in the methods what the sort of relevant time points are. The second objective is to determine the association between statewide stay-at-home orders and modality of encounters, again, in-person, telehealth, and video for veterans in the HUD-VASH program. In this analysis, an objective is guided by a working hypothesis or theory that statewide stay-at-home orders would not affect the delivery of HUD-VASH case management. Our work is guided by a sort of structure, process, and outcomes framework, which may be familiar to some of you. In brief, structural measures are sort of environmental, policy, or organizational characteristics associated with the delivery of care. And so in our analysis, the primary structural measure is the shift to virtual care in response to COVID-19. And so we'll have, again, a sort of pre-COVID-19 / pre-shift to virtual care and a post sort of shift to virtual care COVID-19 era. And what we want to do is understand how outcomes have changed. There's a direct link between structural measures and process measures. Process measures can be thought of as the characteristics of activities that are done to and for veterans, in our case, enrolled in HUD-VASH. Process measures in this case include overall utilization of HUD-VASH case management, and again, modality of encounter, in-person, telephone, and video. And so we're going to understand how changes in these structural measures affect the process measures. Within the sort of structure, process, outcomes framework, obviously another set of important measures are outcomes themselves. Outcomes are measures that are meaningful from a veteran and program perspective. So these could include things such as veteran engagement in outpatient care, housing retention, satisfaction with care, quality of care, type of exit, positive, negative, neutral. For our purposes, and today, we're going to talk about the relationship between the structural measures and process measures, but we're now collaborating again with Jack and Dina and the National Center on Homelessness Among Veterans to sort of disentangle the causal pathway between structure, process, and outcomes. And we hope to have some results on how COVID-19 and the associated shift to telehealth affected outcomes in the coming months. So for our study and analyses, we're going to draw on VA data. Specifically, we're going to use data from the VA Corporate Data Warehouse, or CDW. We're going to query CDW between March 2019 and August 2020. CDW is powerful in that it provides information on veteran enrollment eligibility for VA care, demographics such as their age, gender, race, marital status, and medical records, so diagnoses for anything from depression, diabetes, dementia, to congestive heart failure. Everything that would be coded in a medical record, we can use to identify whether or not they have a certain chronic condition. We're going to link CDW with data from the Homeless Operations Management and Evaluation System, or HOMES. HOMES is Homeless Programs Office operational data that provides information on veteran housing status, veteran homeless program use, as well as, and perhaps most important for our work, whether or not a veteran is enrolled in HUD-VASH, so the month of enrollment and when they disenroll, and so we can see all the time points that they remain enrolled in HUD-VASH. CDW homes are going to be used to evaluate the first sort of objective, which again is pre-post the change to virtual care in response to COVID. How has case management utilization changed? For the second objective, which is understanding the relationship between statewide stay-at-home orders and utilization of case management, we're going to link CDW homes with public data that's been compiled by the New York Times on which states, including DC, implemented a stay-at-home order between March 1st, 2020 and April 30th, 2020. March 1st to April 30th, 2020 is roughly the first wave of statewide stay-at-home orders that were implemented when the pandemic sort of started. As the pandemic continued and our collective understanding of the virus and how it was transmitted evolved, states and their policies also evolved. But we're going to focus on this initial time period, March to April 30th, when we knew relatively little about the virus, and many states were acting at the executive level within the state itself to try to restrict movements through statewide stay-at-home orders. So our analysis is all about veterans that were in the HUD-VASH program. And so our study essentially uses the same inclusion criteria as the HUD-VASH program itself. Veterans are eligible for HUD-VASH if they have a history of homelessness, if they're eligible for VA healthcare, if they live in the US and they need supportive services to maintain their housing stability. And so we used HOMES data, again, that's the homeless program's operational data, to identify veterans with at least 1 day of HUD-VASH enrollment anytime between March 2019 and August 2020. And what we'll end up doing is censoring observations from veterans during the months they were not enrolled in HUD-VASH. And then we also excluded a very, very small number of veterans from our analysis that had either multiple enrollment dates without separating disenrollment, or had some missing data on demographics, medical comorbidities, which I'll sort of touch on in a minute. But it was a very small number of people that were actually excluded from the analysis. So in total, we're going to evaluate sort of 7 key HUD-VASH process measures. Each measure will be evaluated on sort of a monthly basis. So given, in general, in a given calendar month, we'll see how many of these process measures were used. The first set of process measures examine veteran enrollment in HUD-VASH. And so we'll look at how many veterans are entering and exiting HUD-VASH, as well as the total number of veterans that are enrolled in HUD-VASH per month. In a supplemental analysis, which we'll share some findings on, we also looked at Among veterans that exited HUD-VASH in a month, the proportion that had sort of a negative, positive, or neutral exit. And those are sort of coding designations in the data, which I'll comment on in a bit when we get closer to those sets of results. The second set of process measures we examined was utilization of case management. This was done at the program level overall and at the veteran level. And so at a program level, we looked at total number of case management encounters per month, total number of in-person case management encounters, total number of telephone, total number of video case management encounters on a monthly basis. We also looked at this at the veteran level. So on average, how many case management encounters did a veteran have per month? How many in-person case management encounters did they have per month, telephone, video, and so on. Finally, we examined the proportion of veterans enrolled in HUD-VASH per month that did not have any case management encounter in a given month. So for our first objective, again, the goal is to determine the association or the effect of HUD-VASH's shift to virtual care during the pandemic on these key process measures. So before versus after the transition to virtual care, how did use of case management change? In mid-March of 2020, the VA issued guidance to transition to virtual care at sort of the global level. And our review of the data also confirms that at this time, local HUD-VASH programs were also transitioning their services to virtual care. And so within the data, we're gonna sort of create a demarcation that separates the pre-virtual care era and the virtual care era. And so the pre-virtual care period or era will consist of June 2019 to February 2020. And the virtual care sort of period will consist of March 2020 to August 2020. For objective 2, the goal, again, is to determine whether statewide stay-at-home orders affected the modality and use of HUD-VASH case management. For this analysis, we're going to center analysis time on the date a state implemented a stay-at-home order. All states that sort of implemented an order did so roughly at the same time, but there was some variation in that. And so for just analysis purposes, it makes it easier to index everything relative to the date that an order was implemented. In total, 43 states and DC implemented some kind of policy, again, at the state level by the governor that said we are trying to restrict movements through the use of a stay-at-home order, all of course in an effort to curb virus spread. It's important to note, I think, obviously there's a lot of variation across states and DC that implemented a statewide stay-at-home order and what that order itself looks like and sort of how strict they were. But we think making a distinction in terms of states that implemented some sort of order at the state level versus state that did not implement an order at this, by the governor is important from a policy perspective. In total, there were 8 sort of unexposed states or states that did not implement, again, by the governor, a statewide order to restrict movements. So for veterans in these states, we assign them an index date of March 27, 2020, which is the average date exposed states implemented some kind of order. Now, within the unexposed states, counties or various municipalities within that state may have implemented their own policies to curb the spread of the virus, including sort of county or municipality specific stay-at-home orders. But again, that was not implemented uniformly across the state. To give you an idea of states that did and did not implement an order, in the figure of the nation, the dark blue states implemented, again, some kind of order at the governor level. The light blue states did not. They are mostly clustered in the Midwest. They're the Dakotas, Iowa, Nebraska, Wyoming, Utah, Oklahoma, and Arkansas. So our analysis strategy. For the first objective, we're going to graphically and descriptively compare outcomes, again, before and after the shift to virtual care. So we'll look at various time points after the shift to virtual care versus a time point that was way before, that is more representative, sort of normal times when people were not even thinking about COVID or the virus at all. And we're going to examine how, compared to these time points after, utilization of case management changed, if at all. For the second objective, we're going to use what's called the difference in differences design and adjusted linear regression. Our regression model will control for potential confounders, including veteran age, sex, race, whether the veteran served in combat, whether the veteran has a service-connected disability, their marital status, and a number of chronic conditions. The results of this analysis and design is an understanding of whether or not there is a differential use of case management among veterans in states that implemented a statewide stay-at-home order compared to veterans that resided in a state that did not implement such an order. All right, so we're ready to jump into sort of the results and our findings. We'll talk about the first objective, which again is sort of pre-post the transition to virtual care. How did case management change? So first, just to give you an idea of the demographic characteristics of veterans in HUD-VASH, the middle column are the characteristics of veterans that enrolled in HUD-VASH in the month of enrollment before the shift to virtual care. The far right column are the demographic characteristics of veterans that enrolled in HUD-VASH after the shift to virtual care. So veterans that enrolled in HUD-VASH after the shift to virtual care were slightly older and a considerably greater percent were greater than 64 years of age. This is about a 6 percentage point difference, which to me seems fairly large and warrants further sort of exploration. Gender and racial composition of the two groups were similar, but about 4 percentage point fewer veterans enrolled in rural areas compared to before the shift to virtual care. So after the shift to virtual care, veterans in HUD-VASH that were entering HUD-VASH, I should say, appeared to be slightly older and may have been coming more from urban areas instead of rural areas. Lastly, veterans that enrolled before COVID also had slightly more comorbidities than their counterparts, although the difference is perhaps not that meaningful in practical terms. So in terms of HUD-VASH enrollment, the line itself depicts the number of veterans with at least 1 day of enrollment in HUD-VASH in each month. Again, February 2020 is our demarcation for sort of the pre and post period, which is when sort of VA and others really across the nation started shifting healthcare services and social services to the extent possible to virtual care. Although the first confirmed case, I should note, of COVID in the US was January at some point, I think late January. In the pre-COVID period, there was a steady trend in increasing HUD-VASH enrollment, and this trend essentially continued over the COVID era. If we were to compare sort of August of 2020, which is sort of summer of COVID, if you will, to the previous year, there was roughly a 15% increase in the number of veterans enrolled in the HUD-VASH program. One thing we're working on is that it's actually hard to disentangle how much of this growth is, if you will, a COVID effect versus a natural growth of the program. For example, in the early phase of the pandemic, the trend in program growth appears fairly similar, stabilizes, flattens off, if you will, compared to the pre-pandemic or pre-shift to virtual care period. But then roughly by June, there's a large increase in program enrollment. And so we're now, again, with the National Center on Homelessness Among Veterans, where Jack Tsai, Dina Hushire are working with them to try to statistically disentangle the historical sort of program growth from sort of a COVID effect. So the previous slide was about program growth, or number of people enrolled in the program on a monthly basis. We saw it was increasing over time. The next series of slides and what we have here are about program entries and exits. And so the purple line shows the number of veterans that entered HUD-VASH each month, and the blue lines are veterans that transitioned out of the program each month. So as expected from the previous data, HUD-VASH entries are outpacing exits or greater than exits at all time points. In the pre-pandemic period, which is the shaded region, trends were fairly stable in terms of entries and exits. Increases in exits were met by corresponding increases in exits, and decreases in entries were met by sort of corresponding decreases in exits. And for the most part, the lines are fairly parallel and move in unison. Then during the initial phase of the pandemic and shift to virtual care, we saw a steady decline in entries and exits. Again, entries outpaced exits, but they declined relative to their sort of pre-pandemic trends and values. By summer, June 2020, entries and exits picked up, but the increase in entries really outpaced the exits. And so around April 2020, entries and exits had reached sort of their low point during the pandemic era, or at least the window of time we're looking at in the pandemic era. But then they started to increase, such that from April to August 2020, entries had increased by 52%, but exits only increased by 9%. Again, for the most part, on average, entries and exits remained below their pre-pandemic levels. So among people that exit HUD-VASH, VA and the HUD-VASH program worked to determine whether the veteran that transitioned out of the program had either a positive, neutral, or negative exit. In the HOMES data, a positive exit is coded as a veteran leaves the program because they have accomplished their goals and no longer have a need for the program, or they're no longer financially eligible for a voucher. A neutral exit is coded in HOMES as a veteran transfers out of the program to another HUD-VASH program site. The veteran has found or chose other housing, or the veteran is no longer interested in participating in the program. And then a negative exit is coded in HOMES as a veteran did not comply with case management. They were evicted from their HUD-VASH apartment. They were unhappy with HUD-VASH housing, or they could not be located or were too ill to participate in the program itself. And so we looked among veterans that exited HUD-VASH on a monthly basis, the proportion of exits that were positive, neutral, or negative. And as many of the figures before, the pre-pandemic, pre-virtual care era trends were fairly stable. On average, over that period of time, more than 50% of exits were negative. That's the top green line. 30% were neutral, the purple line, and a little more than 20% were negative. That's the bottom orange line. During the initial stage of the pandemic and after the shift to virtual care, there's a notable decrease in negative program exits, especially compared to the pre-pandemic trend. At the same time, we observed increases in neutral and positive exits. Then by summer of 2020, neutral exits continued to increase, but positive exits started to decrease relative to their peak in the sort of pandemic era, and negative exits slightly increased. Still, negative exits in August of 2020 were 4 percentage points lower than their pre-pandemic levels, which represents a 19% decrease, which is rather large and a sort of impressive finding, and something that we are now trying to investigate further to understand what was being done and what could potentially be replicated moving forward in the future. So to reiterate, at a macro level, the number of veterans enrolled in HUD-VASH excuse me, continued to increase in the COVID sort of virtual care era, at least during the period of time we're looking at. Some of these increases are due to natural growth in the program. Some may also be contributed, obviously, by the pandemic itself. Again, we're working with Jack, Dina, and the National Center on Homelessness to sort of statistically disentangle these two effects. In addition, veterans that entered HUD-VASH during the pandemic era, virtual care era, were on average older and more likely to reside in urban areas compared to their sort of pre-pandemic counterparts. So with this context in place, it's time to sort of get to the meat of the analysis, which is about examining HUD-VASH's shift to virtual care on case management. So first, we're going to look at total program encounters per month, and that's what you're seeing on this figure here. Before the shift to virtual care, the program averaged on a monthly basis close to 80 to 90,000 encounters across all the veterans enrolled in HUD, with at least one day of enrollment in HUD-VASH in a month. On average, if you add them all up, all the encounters up, these veterans received close to 80 to 90,000 encounters. About 2/3 of these encounters were face-to-face, and about 1/3 were phone. Video, which is the bottom sort of yellow line, were seldom used, and I think actually in some of these months the actual amount was 0. After March 2020, the number of total encounters greatly increased. The shift to virtual care also resulted in a large decrease in face-to-face encounters and a large increase in telephone encounters. They essentially switched, if not telephone actually overtook in the sort of pandemic era, virtual care era, the pre-pandemic levels of face-to-face encounters. We also saw an increase in the use of video encounters. The increase was large in sort of percentage terms, but in sort of absolute raw numbers, video encounters, again, were sort of seldom used if you look at sort of the amount of video relative to all the other types of encounters that are occurring. So the previous slide was about program level encounters. We saw that they increased, which could be due to sort of more veterans being in the program, but it also could be due to more contacts per veteran or a combination of both. And so to help disentangle this idea, we examined encounters per veteran per month, obviously among those that were when they were enrolled in HUD-VASH. In the pre-COVID era, veterans had on average 2 contacts per month with case managers. Again, most of these were in person. But after the shift to virtual care, encounters per veteran increased. This was likely due to the switch in modality of encounters, which was, again, more prominent were phones. Again, what's interesting here is that in the virtual care era compared to the pre-pandemic era, telephone encounters per veteran pretty much overtook what face-to-face encounters, the predominant modality in the pre-COVID era. Also note that while VA and HUD-VASH switched to virtual care during this period of time, there were a lot of other things obviously going on. And so VA worked, they put in a lot of extra work to try to connect with veterans in the program, given the sort of public health emergency and national sort of period of uncertainty that was affecting everybody. So the program itself was definitely, I think, cognizant of obviously all the other things going on, and made extra efforts to try to connect with veterans. So empirically, if we examine the change in outcomes, we can compare, for example, March 2020, which is right after the introduction of virtual care, to June 2019, which was, again, a period way before the pandemic and before anybody was thinking about sort of COVID and sort of all of this stuff. We can see that on average, in March of 2020 compared to June of 2019, veterans had on average about 2.2 more encounters, 0.55 more phone encounters, and a decrease in 0.34 in-person encounters. And then by April, there was a large spike in phone and telephone encounters. By August 2020, again, things started to decline or stabilized compared to June of 2019. Veterans had on average about 0.3 more total encounters and almost 1 more phone encounter compared to this pre-pandemic period, way before people were thinking about COVID. Another program outcome, which is important to think about, is the proportion of veterans that go without an encounter. We examined this on a monthly basis. So in the pre-pandemic period, approximately 25% of programs that had at least 1 day of enrollment per month in HUD-VASH went without an encounter per month. It's important to note, I think monthly encounters are not always clinically indicated. And so less important in these figures and analysis is sort of the absolute value of the proportion of veterans without an encounter, and more the relative change over time. In March of 2020, again, just after the introduction of virtual care, the proportion of veterans without an encounter decreased by 4.1 percentage points, which is a positive sort of improvement. And then began to slowly increase in the following months, but still remained below the pre-pandemic level, such that by August of 2020, veterans there was 2.1, I should say, percentage reduction compared to June 2019 in the proportion of veterans without a case management encounter. Again, this could be due in part to the modality. Phones may make it easier to interact and connect with veterans, as well as other things going on within the VA to try to reach out and connect with veterans in the program during obviously a period of great uncertainty for everyone. I want to talk about now results from the second sort of objective, which is all about determining whether or not there's an association between statewide stay-at-home orders and modality of HUD-VASH encounters. Again, phone, video, in person. Recall for this analysis, we linked CDW homes with public data on whether a state implemented a statewide stay-at-home order. In total, 43 states, including DC, implemented some sort of state order. 8 did not. And again, we centered analysis time on the date of a stay-at-home order. Descriptively, we're comparing here the demographics of veterans that were in HUD-VASH in the year before the implementation of stay-at-home order or the index date. And so veterans in both types of states were of similar age and gender that were enrolled in HUD-VASH. However, there was a greater proportion of white and rural veterans in states without a stay-at-home order, which you may recall is due to the sort of geographic distribution of which states are implementing an order or not. The states that did not implement an order, to refresh you, were the Dakotas, Nebraska, Iowa, Oklahoma, Wyoming, Arkansas, which are much more rural than many other states and skew more towards a white demographic. Veterans in states without a stay-at-home order also had greater rates of alcohol use disorder, diagnosed alcohol use disorder, diagnosed drug use disorder, and diagnoses for depression. So first up, we're going to compare total number of encounters per veteran in 30-day windows before and after the index date. Again, the index date is the date a state implemented an order, or the average date a state implemented an order for those that did not. The purple line in the figure represent average total number of encounters per veteran for those that resided in a state that implemented some kind of order. The light blue line are average encounters for veterans in states that did not implement an order. You can see the lines themselves are remarkably similar. They overlap in much of the figure, and they move in unison after sort of the index date. And so visually, we can see that there's no differential response to a statewide stay-at-home order between states by the type of state. And our statistical analysis confirms essentially what we see visually, that there's no significant difference in the use of, at least in the total number of encounters, by whether or not a veteran lives in a state with or without an order. We also examined in-person HUD-VASH case management utilization, telephone case management utilization. Telephone's on the right-hand side, in-person is on the left-hand side. Again, very similar trends, lines essentially overlap, and there is no sort of statistical significant difference in terms of how veterans are interacting with their case managers by a state's decision to implement an order or not. So to summarize some of our findings, compared to a period before the shift to virtual care and essentially the pandemic, we observed increases in program enrollment, although entries and exits both decreased relative to the pre-pandemic period. Entries remained higher at all time points than exits. We also observed, notably, a decline in negative program exits during the virtual care era compared to before. And we're now working again with the National Center on Homelessness Among Veterans, Jack and Dina, to try to disentangle what has contributed to that and whether or not those lessons learned can be extended beyond sort of this pandemic when things move back to sort of normal times, if you will. In terms of program process measures at the program and veteran level, we observed increases in total encounters, a decrease in in-person encounters, and increases in telephone and video encounters. Although, again, the increase in video encounters was large in percentage terms, in raw numbers and a practical sense, the use of video remained fairly infrequent. And then finally, we found that there was no association between the use or implementation of a statewide stay-at-home order on modality or use of HUD-VASH case management. So what I'd like to do is just end with sort of two concluding slides on what I think are sort of key takeaways, as well as our next steps, and then hopefully have an opportunity for question, feedback, and discussion with you all. So HUD-VASH's shift to virtual care during the pandemic and local efforts of the local HUD-VASH program to contact veterans led to more case management encounters per veteran relative to the prior year, again, regardless of whether states implemented a statewide stay-at-home order. And we think these findings demonstrate the ability of the VA to maintain care for a group of at-risk veterans. Virtual care appeared to be a very powerful tool to increase outreach to veterans in HUD-VASH during the pandemic, while importantly limiting the risk of virus transmission. In the period after the transition to virtual care, veterans primarily engaged with HUD-VASH by phone and few engaged by video. I think it's important to think about what this means. So in-person and potentially video encounters may provide important clinical insights in terms of the veteran's appearance, environment. There's also some evidence that face-to-face or video encounters may help build better rapport between sort of a client and a case manager more broadly. To date, and to our knowledge, there's no data on the effect of HUD-VASH case management encounter modality on housing or health outcomes. So in that sort of structure, process, outcome framework, we don't know how the shift to virtual care affects some of these important program outcomes. And that's work we're now undertaking to try to understand. But randomized trials of virtual care in other disease areas and populations have found telehealth to at least be equivalent to in-person care. Although I'll say again, results do seem in these randomized trials to be somewhat dependent on the population in the diseases. And so there is some variation in terms of results in terms of when telehealth virtual care is equivalent to in-person. So in terms of next steps, we think improving access to telehealth is a priority, but again, equally important is understanding which services can effectively be delivered virtually. Again, virtual care may or may not be the most effective modality for housing insecure veterans who may have challenging comorbidities or could be involved in the criminal justice system. We found evidence that virtual care did not harm sort of process measures, but we have to have a better understanding of veterans and also providers' preferences for virtual care, what they like and dislike about what the aspects they like and dislike about virtual care, and the effect of virtual care on some of these other types of outcomes. Again, quality of care, satisfaction with care, housing retention, etc. And again, we have some work ongoing to start examining whether or not we can disentangle these effects. And so with that, I'd like to thank everybody for their time and listening to some of the work we've been involved in. And hopefully there's, if there are any questions, I'm happy to answer them or just have a general discussion. So thank you very much.
I just sent a reminder out in the chat box for you guys. If you have questions or feedback or comments or thoughts about the presentation, please send them in so we can use them to guide discussion. Eric, that was great information. I was interested in this just because we get a lot of veterans on our hotline that are curious about the programs that the VA announced, I guess, that they would have this year with providing tablets and cell phones and stuff like that. And they're wondering like when it's coming to their VA, how it will look and stuff. So definitely interesting. I had a couple of questions I thought about, and you might have touched on them, but I'm just wondering if you could clarify a little bit while we're waiting for anybody else to chime in. Can you go back to the slide that had the positive, neutral, and negative exits? I think you highlighted two sections where it was like, yeah, and I know you said you guys are working down or working to identify why these like decreases in negative exits and increases in positive exits. So I don't know where you guys are at in looking at that further, but do you have any like indication on why this might be? What do you think?
Yeah, we don't have a good, or at least I don't have a good sense yet. Others may. We're proposing to we're going to do more data analysis, but we're also proposing to interview HUD-VASH case managers across the country, as well as veterans, to better understand their experiences and perspectives during this time period. And we're hoping, and we'll ask some questions about what they think is driving this trend, and hopefully then we'll get a better sense of what's going on. But from the data we've looked at so far, we haven't sort of taken away any key messages yet, but others in the center, national center, may have better insight into that.
Gotcha. Okay. It's so interesting, the decrease in negative exits. Yeah. Okay. Let's see. I was taking a couple of notes. And I don't know if you touched on this in the very beginning, but you guys are looking at this in terms of contact with a case manager, and assuming that increased contact means better management of the HUD-VASH program, right? So like, what sort of qualitative things do you think are missing that maybe should be looked at, I guess, with the quality of case management? Or does that have anything you think to do with the outcomes that you guys are seeing?
Yeah, so that's like, I think, the next fundamental question for us. So we're seeing more contacts, but we don't know how that's affected quality or experience. And it, you could tell a story or make up a story where you think more contacts could result in better quality or not, and that you could make a story that, one in-person encounter is worth 2 phone encounters. So we are that is our next step. And I think that's like one of the most important questions about this. We saw that during this period of time, VA was able to connect with veterans and continue sort of case management with veterans, but we don't know yet how that's affected some of these important program level veteran experience outcomes. And so we're going to be looking at quality in terms of management of certain chronic conditions, such as depression and follow-up after hospitalizations. So those are sort of medical, if you will, quality measures. And we'll be working with sort of program personnel to understand other sort of quality measures that we could potentially evaluate. So that I think that's the question, and that's what we're hoping to address next.
Got it. Okay. So one other question is just, right now there is nothing that breaks down the video versus phone versus in-person on program exits. Like between video and phone, we don't actually know which one is better in terms of exits from HUD-VASH.
We don't know how the type of virtual care affects exits, or how veteran characteristics affect engagement with the types of modality. So these are all sort of high level sort of program trends. And again, next steps are to sort of disentangle, are there characteristics of veterans that seem to engage more or less frequently with the different types of modalities of encounters, and then how does that connect with outcomes? The challenge from a sort of research perspective, analysis perspective, is this is all sort of observational data. We're not doing a trial where we're sort of giving people telephone or video and then seeing what happens. We're sort of seeing what happens in sort of the natural course of the program and whatnot. And so there's a lot of challenges from a research perspective in sort of disentangling what's actually driving the effect. So we're spending a lot of time on trying to think about various research designs, if you will, that will allow us to move away from just statements about associations in more statements about causation, but it's a challenge.
Gotcha. Yeah, it looks like some feedback from our audience that they're very interested in the next step, like very curious about which form would be the best and what perspectives veterans have on like which different types of forms would be the most helpful to them and that interaction with their health conditions and severity of health conditions. So yeah, I think a couple of people asked about Eric's contact information. We just shared that in the chat with you guys as well. And then I guess to kind of close us out here, and if you could wrap us up with the final point, I guess, what do you think the best practice is? I had one pretty blunt question. So the best practice is what?
Well, I'm not a provider. I'm a researcher that was examining how the program responded to telehealth. And so from the data, we can say that at least within this sort of context and period of time, it appears a large proportion of veterans were able to continue case management through virtual care modalities. And so I'm reluctant to give a recommendation on what sort of best practices moving forward are, other than that virtual care seems like a feasible modality to engage with people and veterans in this program. And hopefully our next work will disentangle whether or not virtual care is as effective as in-person care on important sort of clinical program level measures and sort of experience and quality of care. So sorry, I can't give you more, but that's kind of where we are with the data and the research.
Yeah, so stay tuned for
Yeah.
the next, next round of info. All right, you guys, well, that was a great session. I feel like very timely information. It's very interesting. Eric, do you have any final comments or anything? If not, I'm gonna let everybody go ahead and go. We are going to provide recordings from the session and the slides. You guys will get a follow-up email at the start of tomorrow's day, just to kind of wrap up on what we covered today in conference. And that'll be the same way we kind of move throughout the week. So yeah, you'll always get recordings, you always get slides to go back for your reference. Do you have any final points for us, Eric?
No, thank you for your attention and time, and look forward to seeing the rest of the sessions. Thank you so much.
Awesome. Thank you. You guys have a good day. We'll see you later this week.